You guys probably remember I'm Anandi Sheth. I'm one of the infectious diseases physicians at the Grady IDP and with Emory, and I'm going to talk today about drug interactions related to antiretroviral therapy. So just to give an overview, I'm going to first provide an overview of drug metabolism in the Cytochrome P450 system. And then we'll review some class-specific drug interactions, and then a couple of cases and discussion, and follow with Lindsay's case. So just to review some basic pharmacology, so just remember that there are 4 steps that sort of decide about how drug is distributed and excreted by the body. So the first, and these are usually called absorption, distribution, metabolism, and excretion. So remember the processes as a person first takes the drug by mouth. This drug is then absorbed through the gut. It enters the bloodstream, and that process is distribution, where it goes from the gut to the bloodstream through tissues in the body. And then it enters this phase of drug metabolism. This usually occurs for most drugs in the liver, and it involves this oxidation conjugation system where the cytochrome P450 enzymes are very important. And then finally, the drug or its metabolite is eliminated from the body, and this can occur either renally or through the biliary system. And most interactions between drugs and antiretrovirals occur through either the inhibition or induction of this step right here, the liver metabolism step. So just to review how the cytochrome P450 system relates to drug metabolism. So the cytochrome P450 system is a superfamily of enzymes that catalyze drug oxidation. There can be drugs that either induce this system or inhibit this system. So remember that if a drug induces the cytochrome P450 enzymes, it increases the level of that enzyme, which results in increased drug metabolism. That results in decreased substrate or decreased effect or toxicity of that drug. And examples of drugs that induce the cytochrome P450 enzymes are rifampin, phenytoin, or St. John's wort. On the flip side, if a drug is an inhibitor of the cytochrome P450, that decreases the P450 enzymes. That results in decreased metabolism, resulting in increased substrate for that enzyme and thus increased effect or toxicity. And examples of these drugs are amiodarone, fluconazole, or Bactrim. This is a superfamily of enzymes, so there's many different types. Most drugs are metabolized by the CYP3A4 and CYP2D6 enzymes, and both of these are extensively involved in the metabolism of antiretrovirals, mostly the protease inhibitors and the NNRTIs. And then in addition, some antiretroviral drugs induce or inhibit these enzymes, so they can both have an effect in terms of interacting with other drugs that induce or inhibit because they're metabolized by the enzyme, or they themselves can induce or inhibit these drugs and therefore affect the metabolism of other substrates. So these are some common interacting antiretroviral and drug class combinations. So this list is extensive, and I want to direct you to the antiretroviral treatment guidelines because they'll go through each of these drugs in a lot of detail that we don't have time for. But basically, many drugs that we use in combination with antiretrovirals for treatment of other conditions in our patients are on this list, like acid-reducing agents, anticoagulants, azoles, drugs used to treat mycobacterial infections, anti-epileptic drugs, antidepressants, asthma, benzos, many cardiac medications, erectile dysfunction meds, etc. These are broken down extensively in the guidelines, and we'll go through a few examples. So again, reviewing the metabolic characteristics of antiretroviral drugs. So what's important is to know first, is that antiretroviral drug a cytochrome P450 substrate, meaning will it be affected by other drugs that may inhibit or induce the P450 system, or is the drug itself an inhibitor and inducer, and would it therefore affect other drugs that are substrates? So as a reminder, if the antiretroviral drug is a P450 substrate, then you would need to use caution when using that drug with other drugs that are P450 inhibitors or inducers, because that could then decrease the antiretroviral effect or increase the antiretroviral drug toxicity, depending on whether it's an inhibitor or inducer. On the flip side, if the antiretroviral drug itself is an inhibitor or an inducer, then you would need to use caution when using that antiretroviral drug in combination with other drugs that are P450 substrates. Because if those were used in combination, then that could actually decrease the effect of the other drug that you're using or increase the toxicity of that other drug that you're using. And so here are the metabolic characteristics of the antiretrovirals. So really for the NRTIs, they actually don't have any hepatic metabolism, so they're not P450 substrates, and they also don't inhibit or induce the P450 system. And so there aren't that many drug interactions that occur directly related to the NRTIs. However, the NNRTIs are actually substrates of the P450 system, mostly 3A4, and so any drugs that happen to inhibit or induce 3A4 could affect the metabolism of the NNRTIs and need to be either not used or used with caution. And then on top of that, efavirenz both inhibits and induces the P450 system, and so it would need to be used with caution with other drugs that are substrates of the P450 system. Rilpivirine also does this, but it doesn't do it in a significant manner. Among the protease inhibitors, so these are also P450 substrates, mostly 3A4, and they also can both inhibit or induce, but really the main one to remember is ritonavir. You know, remember the way that ritonavir works is that it inhibits the 3A4 system, allowing for increased concentration of the other protease inhibitor. And so that can also affect the concentrations of other drugs that may also be P450 substrates. And those drugs should be either used with caution or not used in the presence of ritonavir. And then for the integrase inhibitors, raltegravir actually is not metabolized by the P450 system, and it's not an inhibitor or an inducer. It is metabolized by a different system and has a couple of drug interactions related, but they're relatively minor. Dolutegravir is a P450 substrate, but not an inhibitor or an inducer. Usually we don't have to worry too much about drug interactions unless there's another drug on board that does a lot to the P450 system. Elvitegravir is a P450 substrate, and it also induces to C9, and then cobicistat, that's not an integrase inhibitor but is used in combination with elvitegravir and Stribild, is a 3A4 substrate and also a strong inhibitor, sort of like ritonavir, of both 3A4 and 2D6, and so it would also need to be used with caution for any drugs that are a substrate of either 3A4 or 2D6. So, and then the entry inhibitors, maraviroc, it's a substrate of 3A4, and so would need to be used with caution with drugs that are inhibitors or inducers of 3A4. The main take-home point from this table is that both ritonavir and cobicistat have complex and similar drug interaction profiles due to this inhibition of the P450 system. And so those in particular, when you're using them, you have to be vigilant about drug interactions, particularly for drugs that have important side effects that could be worsened if the drug concentration was increased, or for drugs that have narrow therapeutic windows where it could be problematic if the drug concentration was decreased. So let's go to a case. This is a 35-year-old man with HIV diagnosed before 2010. He was out of care for 3 years and presented with a CD4 count of 12 and 2% and a viral load of 221,000. He presented for HIV care 2 weeks after being hospitalized for both PCP and a pulmonary embolism. He otherwise has no other significant medical problems. He smokes cigarettes and marijuana, doesn't drink alcohol, and is not sexually active. He has a family history of heart disease and multiple family members, and his current medications from hospital discharge are clindamycin and primaquine for PCP treatment due to his Bactrim allergy, as well as prednisone and Coumadin for anticoagulation. He's eager to start antiretroviral drugs and would like to be started on a once-a-day regimen. So my first question is, what daily regimen would you start? A tripla B, Complera, C, Stribald, D, Truvada with boosted atazanavir, or E, Truvada with boosted darunavir? You know, these questions are more meant to be thought-provoking. There's not necessarily one right answer, but let me go through each of these responses and let's talk about the pluses and minuses. So basically, a tripla, it certainly is a potential option for this patient, but you would need to be mindful of the drug interactions, which we'll go through in the next slide. So B, Complera, we kind of alluded to the fact you're curious about his viral load. It would not be a good option for this patient because his viral load is greater than 100,000. So you guys picked up on that. C, Stribald. So you wouldn't necessarily rule it out for this patient, but you do have to be mindful of the drug interactions. And then same with D, Truvada with boosted atazanavir, same issue with the ritonavir boosting. And then E, Truvada with boosted darunavir. So again, we can't rule it out for this patient, but you have to remember that he does indeed have a sulfa allergy, and darunavir does have a sulfa moiety. It doesn't mean you can't use darunavir, but want to be mindful of it, especially if the sulfa allergy was severe. And then also need to worry about the drug interactions with ritonavir. So with this patient, I discussed the various options, and we decided to start Truvada and boosted darunavir. So my next question is, how can we manage these drug interactions? Would you A, increase the Coumadin dose when ARVs are started? B, decrease the Coumadin dose when ARVs are started? C, return for an INR check in 1 week? Or D, we'll need to change the regimen? So here the answer is actually C. So we really, it's not a contraindication to starting Coumadin in the setting of using a boosted protease inhibitor regimen, and you wouldn't necessarily want to empirically increase or decrease the Coumadin dose because sometimes the interaction can be hard to predict, but you do want to be careful when starting the Coumadin and have the patient return for a quick INR check. So how can we manage the drug interactions in this patient? So remember, darunavir ritonavir is going to result in induction of the cytochrome P450 system. Induction means that we would expect decrease in the Coumadin exposure since Coumadin is a substrate of that system. Coumadin does have a narrow therapeutic window and a side effect potential, so it is one of the drugs that we would want to use caution when using with ritonavir since it's a substrate of this system. It is still okay to use with ritonavir as long as we monitor carefully. However, the effect usually occurs in about 2 to 3 weeks. And so if you're going to start antiretrovirals on a patient who's already taking Coumadin, you want to monitor and modify the dose a little bit after starting the ritonavir. So just to summarize the interactions between antiretrovirals and anticoagulation, so in general, we're really worried about particularly the antiretrovirals that I mentioned before that either have induction or inhibition of the P450 system. So with darunavir and ritonavir, they induce the P450 system, and you're usually going to see a decreased effect of the Coumadin. With the efavirenz, remember, it can either inhibit or induce, or both inhibit and induce, and so you sometimes can see an increased effect, and sometimes it's a decreased effect. With elvitegravir alone, technically it induces the system and you see a decreased effect, but usually this is given with cobicistat, which is an inhibitor, so you can see an increased effect. So with Stribald, for example, again, it can be hard, like efavirenz, hard to predict the direction of the effect of the warfarin since you have dual effects. Just to cover the newer anticoagulants for a minute, so rivaroxaban can also have increased concentration with the protease inhibitor, and this can result in bleeding side effects, so it's actually not recommended to be used in combination with protease inhibitors, and this is the same with apixaban. So if you're going to use either of these newer anticoagulants, then you should switch to a regimen that does not include protease inhibitors or drugs that have induction effects on the P450 system. So also remember that these medications may be started by other providers, not necessarily you. So it's important for you to have your patient bring all of their medications to all their visits and to notify you of all of the medication changes. So my next case is a 49-year-old female with HIV/AIDS diagnosed in 2003. She was started on AZT and 3-TC as Combivir with imdinavir boosted with ritonavir in 2003. This was subsequently discontinued due to renal stones. And then she was subsequently started on Combivir with Kaletra, or boosted lopinavir, during pregnancy in 2004. She remained on this regimen and did really well with a CD4 count of 392 and an undetectable viral load, but also had a history of dyslipidemia and was on pravastatin of 40 milligrams a day. So these were her lipids at the time that you saw her. And she also had multiple other cardiac risk factors, including smoking and a strong family history of coronary disease. And so how can we best manage her lipid abnormalities? So you can tell from this, her lipids, that while we haven't calculated her risk factors, it seems that she maybe should be on a higher potency statin, given that her LDL is still quite high. And so how can we best manage her lipid abnormalities? Should we start simvastatin 20 milligrams a day, rosuvastatin 20 milligrams a day, change the lopinavir ritonavir to atazanavir ritonavir, change the lopinavir ritonavir to darunavir ritonavir, or change the lopinavir ritonavir to efavirenz? So I'll keep going again for the sake of time. But basically, let's go through each of these options. So with the simvastatin 20 milligrams a day, so remember she's on a boosted protease inhibitor, lopinavir ritonavir, right? And this statin is actually contraindicated with the protease inhibitor, so we wouldn't want to choose that option. With regard to starting rosuvastatin 20 milligrams a day, with lopinavir or ritonavir, we shouldn't actually exceed 10 milligrams daily of rosuvastatin with lopinavir or ritonavir, so this would not be a good option. We could change the lopinavir ritonavir to atazanavir ritonavir, but remember that she does have a history of stones with indinavir, and sometimes this effect can also be seen with atazanavir, so we would want to be mindful of that if we made that choice. We could also change lopinavir ritonavir to darunavir ritonavir. There's some studies that do show more favorable lipid parameters with atazanavir ritonavir over darunavir ritonavir, and others show that they're pretty much the same. We could also change lopinavir ritonavir to efavirenz, but there is also dyslipidemia side effects of efavirenz therapy. So for this patient, I'll get back to that. So just to summarize the side effect of dyslipidemia with antiretrovirals, so this can be really complicated, but in general, there are a lot of side effects of the older NRTIs, which can both increase triglycerides and LDL. This is much more commonly seen with D4T and AZT, which we don't commonly use, and much less commonly seen with drugs like tenofovir that we use now. So with the NNRTIs, we can also see similar lipid abnormalities with increases in triglycerides and LDL, but sometimes there can also be an increase in the HDL. And with protease inhibitors, we can also see a significant increase in the triglycerides, more than the LDL, and an increase in the HDL. This effect of the protease inhibitors is much more commonly seen with lopinavir ritonavir than the other protease inhibitors, darunavir and atazanavir, that we use currently. So statins and antiretrovirals. So in general, the antiretrovirals are substrates of the P450 system, and will have side effects with the antiretrovirals that affect that system. So efavirenz generally reduces statin exposure, and so the recommendation when you're using a statin with efavirenz is to start low, but then increase the statin dose based on the desired response. But don't necessarily empirically increase the dose of the statin, and don't exceed the maximum recommended dose of that statin. So for ritonavir and cobicistat, remember again that they're inhibitors of the cytochrome P450 system, and they're going to increase the statin exposure, and that could result in more side effects of the statin. And so the recommendation actually really depends on the combination of the statin and the protease inhibitor that you're using. And you don't need to put this table to memory, but you want to just double check the guidelines when you're using a statin and a protease inhibitor in combination. But in general, atorvastatin should be used with caution at the lowest dose with lopinavir and atazanavir, and with darunavir shouldn't exceed 20 milligrams a day. Both lovastatin and simvastatin are contraindicated with the protease inhibitors. Pravastatin has no dose limitations, and rosuvastatin, at least with atazanavir and lopinavir, should be limited to 10 milligrams a day, and with other protease inhibitors should be used with the lowest possible dose. And essentially, you should follow these same recommendations when the statin is used with cobicistat in Straggled. So this patient was actually reluctant to change her effective antiretroviral regimen. So we started rosuvastatin at 10 milligrams daily and recommended diet and exercise. When she followed up 6 months later, her lipid abnormalities were worse, and she was subsequently changed from lopinavir-ritonavir to atazanavir-ritonavir, and the AZT was changed to tenofovir. And this was done despite her history with kidney stones, because there's generally a lower risk of renal stones with atazanavir compared to indinavir. And so in summary, I'll just go through a couple of common challenges. So one common challenge relating to drug interactions is sometimes it can be difficult to distinguish whether a side effect is occurring because of multiple concomitant medications or the multiple comorbid conditions that the patient has. For example, if a patient has a rash, it can be sometimes hard to distinguish whether it's due to trimethoprim sulfa or whether it's due to efavirenz that they're on. If they have nausea, vomiting, it could be due to sulfa, or it could be due to protease inhibitor. If they're having a transaminitis after starting antiretrovirals, it could be because of a hep B flare or immunoconstitution or an antiretroviral side effect, or due to another drug that they're receiving. Another common challenge is the use of antacids with either rilpivirine or atazanavir. I'll postpone this discussion for a little bit. Another thing we see commonly is the use of inhaled corticosteroids with ritonavir-containing regimens. So again, you want to make sure that you are avoiding inhaled corticosteroids that have a drug interaction with ritonavir, and use ones that are more favorable. Also, another common challenge is patient questions regarding interactions with herbal medications or over-the-counter medications. And I would definitely refer to the drug interactions guidelines and some of the references I'm going to give you on the next slide if these come up. But my general take is if a drug is not studied, then I usually, overall discourage the patient from using the herbal supplement if it hasn't been studied with antiretroviral drug for drug interactions, or at least tell them that they'll be using this with significant caution. And then finally, I didn't go over this because of time, but there are a lot of interactions between antiretroviral drugs where the drugs need to be dose adjusted due to interactions with each other. And so it's important when you're using two antiretroviral drugs in combination that we don't commonly use, that you check with the appropriate tables in the guidelines to see if they need to be dose adjusted. So remember these references. I encourage you to look at these tables that are in the treatment guidelines. It's sections L1 through 41. It looks really long because it's 41 pages long, but it's really in some nice tables where you can just hone in on the table of the drug that you're interested in. And these are mostly in tables 17 through 19. And then I put down 3 useful websites where you can actually search by interacting drug or by antiretroviral drug or even by interacting drug class that you may find useful if you come across antiretroviral and interacting drug combination that you haven't seen before. And certainly always use your mentor as a resource.